Well, why don't we get started? So I want to first welcome everybody to the webinar, How to Introduce T-Scan to Your Patients. This is obviously a very important topic because you can use T-Scan, but if you don't know how to talk to your patients about T-Scan, it's not going to be as effective of a tool as it can be. And we're lucky enough to have Dr. Sutter here with us today to talk about this. And he's definitely someone that uh, doesn't just preach it, but actually does all this in his practice. He uses T-Scan on a daily basis in his practice. So before I introduce Dr. Sutter, just a couple of things. If you have any questions, there's a Q&A section down below. Just type your questions in the Q&A section and we can answer that most likely at the end of the session. There's also going to be a survey at the end of the webinar session. So if you have a few minutes, we appreciate you taking time to let us know your thoughts about whether it's the speaker or maybe some other content that you wish that you would like to see with this. And like I said, at the end of the question and answer session, at the end of the webinar, we'll do some question and answers for about 15-20 minutes. This webinar is probably going to be about, what, 30-40 minutes?
Yeah, something like that.
So without further ado, I don't know that Dr. Sutter needs a whole lot of introduction. He's been, I think most of you know him. He's based out of Eugene, Oregon. He actually just took on not a new practice for him, but an existing practice. So, he's going through a lot of what he's actually going to be talking to you about with his own patients as well. So, Dr. Sutter, the floor is yours.
Hey, thanks, Shane, and thank you, TechScan, for allowing me to kind of share my passion. And what I hope to get across to everyone who's going to attend or watch this later is how to introduce T-Scan to your patients, because I hear this over and over whenever I present or lecture, and it's like, well, I have T-Scan, but I only use it for the big cases, the really tough cases. Your all-on-4, your full mouth rehabs, your cosmetics, and it's good to use it for that, but man, you're missing a lot by not making this a part of your practice. And so a mainstay of the practice. And the other part is people will comment and say, well, I just really don't know how to integrate this, and how do I bring this up to my patients? Because I've been practicing for 20 years, and my patients are used to doing things one way, and then I'm going to go 180 degrees and go off in another direction. And what are they going to think about me and all this? And those are valid concerns, but I mean, a few sentences and choice words kind of negates that whole thing. So you shouldn't be afraid to push yourself forward for the benefit of the patients and your practice, your business. And I'm going to share a little bit of that with you today. I know we've all worked, or we're probably, if you're on the West Coast and you're watching, you just got done with your day and you're tired and you want to go home. And if you're on the East Coast, you probably are sitting, on your couch in your jammies watching this. So look, this is not going to be a full hour. We're going to hit the salient points that matter, and then we'll move on to the Q&A. Okay. So this is me. If you want, my contact information is all there at the Popple code. You can take a picture of that. You can get my cell number, my email, my Instagram, Facebook, whatever. You can get a hold of me. If you do reach out and text me, just let me know where you saw me so I can get some context, because this is clearly not the only webinar I've done. Okay. So I'm coming to you guys from Eugene, Oregon. And when I say that I practice in Oregon, most people think of Portland. No, I'm 2 hours south and kind of in between Portland and Crater Lake, and this is a shot that I took at Crater Lake last year, and trying to get back. I'm actually going to go out there tomorrow and try to get the Aurora Borealis, which is what you're seeing over here, this orange and pink, and then in the middle there's some green and purple before you get to the Milky Way. Crater Lake's one of my favorite parts. And if you came in and listened to Shane and I talking, I'm getting ready to go on vacation, and I'm going to go see 6 more national parks. So it's on my list to do them all. So when I say Oregon, think of this, don't think of Portland. Okay, so I'm sharing some cases and some slides. The presentation is HIPAA compliant. So the patients have given me permission. They haven't given you permission. If you want any of my slides, just ask. I'm happy to give them to you, but I do have to have, or we have to have permission from the patients to do so. I am not a paid consultant for T-Scan or any, or TechScan or any dental materials or technology company. And I don't get paid if you buy a T-Scan. And I'm a private practice owner, single person doing my thing, and I'm just sharing on with everyone what I'm observing in occlusion and TMD, which are very volatile topics in dentistry today. Almost so it's almost a religion to some. I don't get too wrapped up in it, but it's interesting. You need less and less what's the word? Icons in occlusion and TMD when you start having your own data and you're making decisions based on what you see, not what you've read. Because a lot of what dentistry has, unfortunately, is like, yeah, this is what I do in my office, and if you just do the same thing I do, you'll be successful. And I know if you've been practicing dentistry for a few years, you know that's not true. Plus, there are several things that dental school teaches us that don't hold water either. And unfortunately, they're still teaching the same things. And we all know that. So what really drives the market? And it's, we want white teeth and we want straight teeth. That's what really patients come in looking for. Not many people pay attention to function, and that's sad. The whole profession is asleep on the subject of function. Whereas if you go to something like, a cardiologist, everything they do is about increasing function of that system. And so, I take a little heat for saying that, because some guys or ladies will say, well, I care about function. It's like, okay, when's the last time you did a mastication evaluation on your patient? And all of a sudden the room gets really quiet. Well, what other function do we have other than to chew? And some people must say, oh, well, no, to smile. No, that's really a function of the 7th cranial nerve. It looks better if there's some veneers underneath there, or the teeth are brighter, or they're straight, but that's not really a function. Okay. So one thing that I think is smart to do, if you haven't already done, is before your patients even get into the practice, right, it should be introduced to them on the web. I have many people who have come to the office and say, I had somebody else did some dental work for me, and I really couldn't, the bite wasn't right. And I started doing my own research. I went back to the doctor 2 or 3 times, and he or she couldn't really get the bite right. And I don't really have confidence that they know what they're doing at this point. So I found the TechScan website. You were in the database, and I found you from that. All right. So that's one avenue to make sure you have greater awareness. And then you should have like a technology page. And this is my a little snippet I put of T-Scan, but of course, most of us have this now with digital x-rays and CBCT and lasers and all of that. This should 100% be on your technology page, right? So I would start there. Online presence for sure, having opportunities in social media to kind of show what it is that the practice is kind of like your branding. I certainly have my my own. Oops, I have my. Looks like I cut off a slide. What I was going to say is I have my own YouTube page, and we'll get to that. So patients are in the office, and you should have examples of your work on the walls. We have a before and after book that sits out on the coffee table. Thank God COVID's over, right? We can bring that back out, and patients aren't afraid to touch it, and they can go through it and see what you're all about. And then also treating your teeth using T-scan, and you already have team members that are suffering, and maybe you built a night guard here or there for headaches or migraines or TMD type symptoms. A lot of this can be rectified or improved by using your T-scan. So yeah, you walk into my office, and you immediately get a flavor for, okay, what is this office about? You don't see the gummy diagrams of the periodontal probe and the 4 stages of periodontal disease. Like, that's not what we do here. We do cosmetics, and we do function, and we do it at a very high level. So just walking into the practice, that this is not an amalgam practice, right? And so if this is kind of the similar things that you want to impart on patients, it does a lot of selling without you having to say anything, because I want his smile, or I really like the way these veneers look. Can you do that for me? So and what does drive awareness? Because we've got these nice multi-volume books that are out there for docs to make sure that they're bringing their A game by some of the best in the industry that are using T-scan at a very high level, and those are available to you. But what drives the awareness? And it's not the science, it's not the books, it's not the publications, it's certainly not the profession, it's the patients. So you have to make sure that that is a part of your message, and we're going to go through that. So this is the first edition in black. The second edition is in blue. If you go to the IGI website and use a purchase code of IGI 50, you will get 50% off. They're unloading these books as fast as they can, because the third edition is being written as we speak. And I don't make any money on the sale of the book, zero, but I think it's a great chapter 4, chapter 7 would be chapters that I would want to read. Oh, and by the way, I would say if you go to their website, IGI Global, you can buy a PDF version of just chapter 4 and chapter 7. Use the IGI 50, and I think it's 50% off. Those chapters individually are in a PDF format, and I think they're around $35-40. They're worth having, and if you're like, hey, this makes sense, I want more, go back and get the book. So here we go. Here's my YouTube channel, and I love the social media aspect. In fact, I'm making a bigger investment. Excuse me, in the social media arena, because once these things are on, they are running continuously. And it's another way to market yourself, and patients have made the purchase before they come in. And take a look at this, a tongue fibroma removed. I'm using my CO2 laser to remove a little fibroma. 208,000 views, and people are traveling from all over the state and adjacent states. Like, yo, man, I don't want a blade. I want you to remove this with a laser. And so you can also see me doing T-scan, DTR type therapy with T-scan, and 20,000 views, 18,000 views, 23,000 views. There's 23,000 views here. These things work continuously, and they are great at growing your practice. So like if you want to do more implants, you know, build a case presentation and show it and do some testimonials. But that certainly works for T-scan, and not a lot. There's a lot of people doing all on fours. There's a lot of people doing cosmetics, but function and understanding occlusion, trust me, no one's doing it. No one's paying attention, and there is a huge need for it. Okay, so you need to treat your T-scan and your T-scan data as you would your x-rays and your, you know, your intraoral camera. So when you see this in the patient's mouth, it's easy, right? Because you can show the patient, oh, look at the, let me just grab my laser pointer here. You say, yeah, look, Mrs. Jones, you got this abscess going on here. And they're like, well, you know, I don't feel any pain. Can I put it off? No, this is an abscess infection, and you got to take care of it. Otherwise, you know, it gets worse and it can involve other teeth. So you get the root canal, you get the buildup, you get the crown. It's like $3,500, being very conservative. But the patient can see this, okay? They don't need to be a dentist to know that this is very different than this, okay? Same thing with your, you know, your intraoral crown or your intraoral camera. When you see an old filling and part of the tooth broke off here, and they've got fractures, like this is a crown. We've got a leaky, large occlusal composite that just looks like it's got 100,000 miles on it. It's a crown. It is what it is. The patient sees this and they just like, dude, can you take care of that? That looks horrible. And if you've used an intraoral camera, you've heard this many times. And so the same thing holds true with T-scan data. So when you look at this, this is a night guard clearly, and you look at that and you're like, wow, we've got centric stops and not a lot of interferences are hitting the inclines on this night guard. And it certainly looks like all the dots are even and evenly distributed on both sides. But when you throw it on a T-scan, it's 60-40. Like this is lying to you, right? And so when a patient sees this on the screen, it's equivalent to seeing the photograph of the broken tooth with the recurrent decay underneath the filling. You don't need to go into some huge lecture like, well, Mrs. Jones, you're looking at a digital occlusion, a digital occlusal analyzer, and what it's telling us is you're out of balance. You know, keep it super simple. Mrs. Jones, this is a bite computer and it tells me force distribution and you're off. And these are the two numbers that I'm looking at down here. You may be doing all sorts of adjustments to this, but hey, we want to make it 50-50 or within 5 percentage points. So I think the patient doesn't need a whole dissertation on this and get lost in the weeds. Usually when they see this, they start tapping their teeth together and they're like, man, I feel exactly what that's showing you. And now what you have is a common language that has never existed before in dentistry, where the dentist and the patient are speaking the same language when it comes to occlusion. So, oh, well, here's the other half of my my slide that got cut off. So once the patients get into your office, let's say we've taken care of our web page, and we have T-scan in the technology section. You also have it, you might have, you know, this, what am I looking, culture and branding in your office as soon as the patient walks into the office. So then what? You know, as new patients are coming in, it took me a while in my own journey, you know, to get comfortable with the technology to a point where it's just expected. And so when a new patient comes in, you know, the conversation goes something like this, you know, Mrs. Jones, my responsibility to you is to tell you all of my concerns. And so my hygienist is going to, you know, take some x-rays, we're going to do some periodontal probing, and we're going to check the bite. And that is what traditional dentistry is responsible for, right? So it's not about just taking, looking at the bite and saying, okay, I'm going to write down my overbite. This is my overjet, angles, class 1 molar occlusion. Good. We never talk about the bite again. Or maybe you're going to take some, models and you're going to mount them. That's great. The patient isn't going to understand what it is that you're looking at anyway. And it's not going to tell you anything about timing. It's not going to tell you anything about force distribution profile, right? That's what the T-scan is going to give us. The other thing is, and most of the profession is ignorant of this fact, is occlusion does change, just like your periodontal status, just like your decay status. And so what are you going to do? Mount models once a year to check this out and confirm what you think you know? No, you're going to use a $7 sensor or $8 sensor. And in less than a minute, you're going to have a ton of data so that you can talk intelligently. Hey, Mrs. Jones, the bite looks stable. I don't really see a change. It's like 5% variation from last time. Or, wow, it's no longer 50-50. Now it's like 80-20. What the hell's going on? Let's take a cone beam. Let's look at the joint, see if there's any changes. Have you had trauma? Are you a mouth breather? Are you sleeping on a CPAP? I mean, there's a number of things that I think would spark another conversation to follow up with that patient, right? And so patients that are coming in that have multiple handles, and this is something you might think about if you go down the road and you start getting really comfortable. Running around the office with one T-scan from op to op makes about as much sense to me as running around the office with one X-ray head. No, you have an X-ray head in every unit because every op needs one to check things on the fly. And so I don't have, well, I actually do have a T-scan in every op, but for years I practiced with one hygienist. She had her own handle, and then I had my own handle that bounced from room to room. So new patients, I don't want new patients to wait. And when I want information, I don't want to wait on the hygienist to get my answer, right? And so new patients can come in from hygiene, or if they're coming in from your side, your dental assistant can set up the software for you and do some screening bites, as long as she's trained up on how to do it. And hygiene can do the same thing if they're coming in on their side. And you want to make sure you ask the right question. If you see something crazy like 35% of total bite force on one tooth, follow up with the question, hey, have you had any new dentistry lately? And they're like, yeah, I just had a crown placed, and I'm here in your office because it just doesn't fit right. Or, yeah, I had a wisdom tooth taken out that was really hurting, and now I feel my bites changed. It's great to, get some feedback from the patient. So just, have a small handful of questions to ask the patient, and then you can segue right into, all right, as part of your new patient experience, I'm not really concerned with your probe depths. Everything's like a 3 or a 4. I think we could tighten that up a bit and get all 2s and 3s. My hygienist is going to show you how to do that. Just do whatever she or he says. And I don't see any decay, but oh, look at your bite. This is how you read this. We generally don't want you to have too much force on any one tooth. There are some rules that we follow, and I'm going to go through that with you in a case presentation in just a couple of minutes. So here you go. Here is Miss Jessica. She graduates from the pedodontist. Her parents are in the practice, been in the practice for decades. And so what happens is she had ortho that was done a few years ago. She's no longer wearing her retainers. So the bite has had plenty of time to settle in and to create whatever home base the rebound the ortho occlusion is going to create, right? They say 6 months, it's been 2 years, and she admits, I don't wear my retainer. It's been a while. So here you go. I'm looking at this, and for my eye, looks like the midlines are on pretty good. I don't have any concern there. Tissue looks pink and healthy. You know, I mean, these are all brand new teeth. That's exactly what you should look like when you're 18 years old. And the overlap and overjet all looks good. Not too concerned about too much going on. Periodontal probing, she's got a 4. This looks like somebody who's just going to go right into your hygiene department, and you're not going to have anything to do for a couple of years, right? Well, this is part of my intake on Jessica, is we do a T-scan on her and evaluate what that occlusion is doing. So she's got about 40% of her total bite force is on the front 2 teeth. Now, Jessica's new to me, and she doesn't know me from a hole in the wall. Mom and dad have known me for years. I'm like, hey, Jessica, you mind if I get mom back? She's like, yeah, sure, whatever. So I bring mom back, and I'm like, hey, this is what's going on. I gotta tell you guys what my concerns are. These 2 teeth are overloaded, right? And you don't need to go to dental school to look at this and get some kind of understanding at a layman's level of what's going on. And so mom's like, well, I just paid $7,000 to have her bite fixed. I'm like, no, Mrs. Jones, you didn't. You paid to have her teeth straightened. Her bite is not fixed. And that's not what ortho does. They don't create bites, they create straight teeth. So the nuance there of, well, okay, so, well, what was he doing and how come he doesn't have this? And, you know, that's a great question. I can't speak intelligently on what another doctor uses as technology wise or not. Sitting in my chair, looking at this, I can tell you that this cannot stay like this or this configuration can't stay like this for decades, because she's going to start chipping teeth. And then when she's in her 30s, she's going to become self-aware and like, you know what? This chipping thing's been going on for a while. And maybe I'll go get some veneers. And then you prep veneers and you don't have this information. What do you think is going to happen to those veneers, at least on 8 and 9? They're overloaded. Can they pop off? Sure. Can they break? 100%. Absolutely. So it's good to have this information from the ground, because I just transferred all the responsibility for this case to the patient. She owns it. I don't own it. And so any dentistry that's needed, hey, we need to correct this bite. We need to get you a splint. We need to do something, or put you back in ortho, and she's going to tell you to kick rocks, right? Because she just got out of it. She just wasn't a pleasant experience to begin with. So this is a great way, I think, for docs absolutely to get some instant trust and some street credibility with patients. Right. And so the big question is, you know, how long is it going to take this to turn into something like that? It's going to take decades, but all she has is time. She's 18, right? So here's another ortho case, picking on the orthodontist today, or if you're a GP doing ortho, you know, it looks good, but if you were doing the ortho in this case with a 70-30 distribution of force high in the anterior, you know, are you happy with that case? Does that, when you go home at night, do you sleep well? Or are you worried about some of the things that she was complaining about? You know, she's had ortho done twice, still not correct, out of braces for 6 years now. So anything that was going to settle probably would have already settled. And she's had ortho done by 2 different providers, and she suffers from headaches and migraines. Not that you have to go looking for these patients. You don't. They're already in your practice. I promise you that. All right. So how many of us are, if we're not placing implants, we are restoring them. So let's go through this case. This is not my case, but I inherited the patient. So I will just walk through it. Okay. So when I went through school at Rutgers, that I was told and taught, and when I did my AAID fellowship maxi course, I was told that bone loss to the first thread is acceptable. Now, here we have an x-ray in 2012, and the height of the bone is way up the neck, okay? Bone comes about right here, all right? And this is a check x-ray. This is a full mouth that was done by one of my predecessors on a practice that I bought. And this is the check film before to make sure that, you know, this is seated completely and engaged before they put the crown on, and it is. So in 4 short years, what we have is our height of bone comes down to about right here. Okay, and I'm sure everybody on the webinar can see that. So my hygienist, who's very astute, says, hey, we need a T-scan her. I think we have an overloaded implant. And I'm like, wow, I'm glad I didn't do that implant. Well, I'll hold on a second. You're still responsible for that implant, Sutter. You just failed. You failed the patient. So it's not your fault, but it is your problem because they were under your care. And so what you have is this lady's in her 70s, but she has no periodontal disease anywhere in her mouth. She's got a peri-implantitis. Now, what do you think? I don't see. Okay, so let's just go through our possibilities here. We were having a lot of failures in implants because the bone got overheated. So we turned down the RPMs of the drill and we irrigated it with saline. So we can check that off our list. And then dentists were leaving inordinate amounts of cement. Well, it doesn't look like there's any cement here, so we can check that off our list. And the one thing that we're not doing, and still just so puzzled when this happens, is the patient has zero proprioception on implants because there is no nerve and they're being overloaded. So that's what we suspect is going on. So I get out my handy T-scan and I'll look at this, and the implant is on number 19, which supposes 14. It's 20%. And it's the most heavily loaded restoration of the full mouth of any other restoration there. So we've confirmed what we suspected, right? And all three, so I took a multi-bite. The first one was here, the second one is this bite, the third one is going to be right here. And you can see in all the bites, this is the most overloaded restoration, right? And so what do you think happens to that implant? Well, it's just a matter of time. If it's got 50% bone loss, clearly the patient can't keep it clean. And if you haven't changed the amount of force that implant is getting, it's never going to stabilize, and you're just going to keep losing bone until finally it's on a piece of gauze sitting on the countertop. Okay. Every single implant that you restore, you need to verify it's not overloaded with a T-scan. You got to have it. There's no debate. You have to have it. You got to make this part of your armamentarium, guys. And I'll give you a real quick tip. If we go back, how would you design your occlusion based on this configuration? I would want this tooth and this tooth to have more force than this implant. Why is that? Well, they have a PDL, the implant does not. So there's going to be some compressibility to the natural teeth that does not exist on implants. Okay. All right. So here we go. I just pulled this out of the archives today. That's why you're looking at black letters on a white screen. This patient, it's brand new patient, new to the office, and she's tired of not being listened to as a patient. She has no perio, no decay. And this is how she presents. Now, it's not a ortho patient, so our midlines are off, but like this doesn't look bad to me. I don't see in any restorations. I don't see really any perio going on. Maybe a little blunting of the attached gingiva here, and it does look like we are missing molars on this side. Okay. So here we go. Put the T-scan in, and she's got 36.4% total bite forces on one tooth. And she's, like I said, she's missing 15. Her story is the orthodontist wanted to take those two teeth out, and so they did. And all right, so we've got 36% of total bite force on 14. You've got 20% total bite force on 2. You've got 55% of total bite forces on 2 teeth. Guys, it's unstable. You don't need me to tell you this, right? So what happens to these teeth if you just look at this and you're like, okay, well, there's no decay, there's no perio, everything looks good. You got some overbite, overjet. All right, see you later. What's going to happen to these 2 teeth? Well, these are going to be the teeth that she's going to come in, at 4:30 p.m. on a Thursday and say, I was just eating some bread and my tooth broke, and I don't know why a tooth broke. I wasn't eating anything hard. And can you fix it today, doctor? Because it's really sensitive when I drink my water. And, you're going to answer the patient however you feel, but wouldn't it be good to know, like, hey, Samantha, this was the exact conversation we had. Samantha, everything really looks good. I don't have any concerns with gum disease or periodontal disease with you. I really don't see any cavities. However, the bite, I've got some concerns about. Look at how much force are on these 2 teeth. What happens if we leave it just like it is and we don't do anything? Well, the answer is in the immediate future, not really, probably too much. You're pretty young. She's, I think, was 30, 32. However, if you leave this for decades, what is the probability that one of those 2 teeth are going to break because they're overloaded? Or they could have a root fracture, and then you don't even get to save the tooth. You got to do an implant. Or you could kill the nerve, and all of a sudden you need a root canal buildup and crown. Or you can have bone loss. So all of these things, just having them at the tip of your tongue where you can, hey, these are a couple of things that I'm concerned about with teeth being overloaded, and I just need to make you aware. Well, she didn't hesitate to treat it and just get the bite revised and optimized. And she says, okay, so, now we cut the amount of force in half, right? And she's like, well, I don't feel any different. That's great. You're not supposed to feel different. We're trying to prevent dentistry, not create it. And so, another, I don't know why anybody would do full mouth cases and not have this readily at their fingertips. So this is a case that I had a guy who teaches occlusion, did a full mouth rehab. In fact, the case started, in 2018, and I was called 4 years later, and the full mouth rehab had been done twice. Okay, this person owns T-scan, doesn't really use it. Okay, thinks that they can read the dots, which none of us can. The ink marks on teeth, and is really struggling. The patient's getting irritated. So I take a flight, I get on a plane to go help this guy out, and we have 3 teeth touching. That's it. So again, when you see this data, you're like, dude, you did an awesome case. You just got to finish it. You got to get this all balanced out so the patient is comfortable and not breaking your porcelain. What are you going to do on tooth number 3 when it's got 42% total bite force on it and they break it? You going to do that for free? Like, I don't want to be in that situation. And the patient never hurt before I did the full mouth, doc. So what are you going to do? You're going to build them a splint? And then all of a sudden, every time they eat, this is what they eat with? No, of course not. Nobody wants that for their patients. So excuse me, real quick, if you want to like know more about T-scan or possible cases, you can join this Facebook group that is T-scan interpretation for clinicians. You have to answer 3 questions, and I always get a surge when I do this. 4 or 5 doctors will answer the admission questions and 1 won't, and I'll just hit delete, because there's no one from TechScan or BioResearch. There's no sponsors in here. There's no salespeople. There's no patients. It's just doctors. It's just clinicians, which is what the title says. So if you want to take part in that, make sure that you fill out those admission questions. And so, you know, whatever you do, I would encourage you not to be afraid to do something you haven't done before to improve care for your patients, and not just Monday morning go right back to the same thing, because that doesn't improve your patient's care. That doesn't improve you as a clinician. All right. And there are plenty of people out there who will practice dentistry the exact same way they graduated from their class, and they'll do it all 40, 45 years, whatever, and not grow. That I don't want for any of us. So look, if you're wanting to take a course that is going to maybe stir the pot for you a little bit, and maybe you've decided you're just not an owner, or so you could either be an owner and want to know more, or a prospect and like, I want to see more, or hey, I want to buy one of these and add it to my practice, but I don't know how to do that. Well, Dr. Kirstein and I, sorry, Robert, you got cut off here in the way that Vivos changed their website structure. You're actually below me, but he's the master of T-scan. He should be at the top and me at the bottom. But you can come and learn with us at Vivos in Denver on September 29th. If you go to the Vivos Institute and look on their calendar or upcoming courses, for less than $1,000, you can really get some great information on T-scan and making that an integral part of your practice. You can also reach out to me. I will come to your office. This is Dean Hutto in Houston, Texas, Alex George in Pennsylvania, and Christine Tenaglia in Michigan. And so I come to your office. You bring 3 to 5 of your toughest cases that you have not been able to get comfortable, and we will get that occlusion dialed in for you. I'm also an AGD provider of CE. You get participation, 8 hours of participation, and your team gets CE if you're doing training with them. So my cell number and email are there. So I'm going to open it up to questions. I told you I wasn't going to go a full hour, and I was going to go 30, 40 minutes. I went 45 minutes. So sorry for that extra 5 minutes. I'm going to turn it back over to Shane, and we can answer questions.
Thanks, Dr. Sutter. While we're waiting for some questions to come in, so when you're doing your T-scans on whether it's a new patient or a patient in hygiene, or someone that's just seeking you out for occlusal information, do you do a complete set? Like, are you doing just a CO bite or multi-bite, or are you actually doing the excursions as well too?
Yeah, I look at the excursive movements too. I didn't talk about that for just brevity of the course, or the webinar, just because we can spend 2 days on this, which is what the DTR course is, right? So I'll do a multi-bite just in a maximum intercuspation, and then I'll have the patient go to a right or to a left excursive movement to see where the interferences are, and that'll keep your porcelain breaking, especially on second molars.
Okay, great. And I think it's good to know that it's not just doing the CO bite, but it's also getting a full set of records so that you know exactly where that patient's occlusal scheme is on there. There was a question that came in that was more about, can you repeat the name of the Facebook group for T-scan?
Oh, yeah, it's right here.
Maybe just put that page up. So then we
T-scan
see.
interpretation for clinicians.
Here's a question: how OccluSense is different than T-scan for non-TMD patient?
Yeah. So I was excited when occlusense came out because it was cordless and they had ink impregnated on their sensors. So maybe you're saving a step. And the sensors were thinner. And I worked for about 2 months side by side because T-scan is the gold standard. It's been tested, it's been proven to be accurate. OccluSense has not. And I think, if I'm going to speak freely, I think people look at OccluSense and think, oh, I can do digital occlusion at, a very reduced price and get started, but there's nothing saying that OccluSense is correct. And I actually wrote a product review. It's been read like 5,000 or 7,000 times at this point. If you go to ResearchGate, you'll probably have to create a profile, which is your name and your email. All of that's there for free and you can read it. And I tested 5 patients, T-scan versus OccluSense, and they try to make it look like a T-scan with the height of the pixels and the colors. They have three colors, which are like green, yellow, and red. And the interesting thing was T-scan, like when you're looking on the screen here, everything that's in pink is maximum force. So the interesting thing about OccluSense was they had the green, they had yellow, and they had red that were maxed out, and then they had yellow, green, and red smaller pixels. So like, how do you interpret that? It's not, the manual doesn't tell you how to interpret that data, and you either have to figure it out on your own. Yeah, I really don't know what to tell you on that because no one's done any studies with it. The value with T-scan is it has been through 10 different software versions, and we're on the fifth version of the handle. So, I wouldn't be able to do what I do. And if you've seen any of the YouTube videos, there's very few people doing what I do. I could not do that with an OccluSense. One of the biggest frustrations with me with that was the ink didn't mark off of the sensor like it does off the AccuFilm. That's number one. And number two, the Wi-Fi is only connected onto your iPad for a very short period of time. And then you have to stop what you're doing, take your gloves off, reestablish the Wi-Fi connection or the Bluetooth connection, and then go back to the patient. Lastly, T-scan has a core version, at least they did, where it's not quite as expensive as all the bells and whistles. It's kind of an introductory thing. It gives you the bite force, and it does give you data, and it's the exact same hardware, but some of the software features have been turned off. So if you're not prepared to spend the whole amount for a T-scan, get T-scan core, get started, and get comfortable with it, and then turn on all the features. I'm kind of like, I want everything. I need to learn it all. Let's go forward, kind of a person. But I would strongly recommend that you read the product review between these two, because I actually do a side-by-side comparison on 5 patients. So long-winded answer.
And just to put my input into that as well too, is everyone that's tested the OccluSense and have tested the T-scan have always seen the information looking different. So you got to decide which one you think's more accurate. Obviously, T-scan's been around for a long time. It's been tested. It's got, a ton of research behind it. As far as I know, I don't think OccluSense has any of that there. So, You
Not
kind
that
of
I've
get what you pay
discovered.
for, and so you got to decide what makes most sense for your practice in there. We have another question here. Do you treat the infected tooth as shown in the presentation before going for occlusal analysis with tech scan?
Do I treat
So do
the
you treat the infected tooth before going for occlusal analysis with tech scan? So do you
no?
treat the tooth before?
Yeah, I would. I would. In fact, if you're talking about the X-ray with the abscess, look, that's obvious. I would do the root canal first because the abscess is going to push the tooth into hyperocclusion, right? That's why endodontists want to take a tooth out of occlusion so the the periodontal ligament has a time to calm down and not be continually traumatized. If a patient came out and they said, "Hey, I've got hot and cold sensitivity," or "I can't drink anything cold," um, but you take an X-ray and you don't see an abscess, you don't see decay, you don't see a widened PDL. Yeah, I would be inclined to put them on the T scan. I'm like, whoa, that tooth's really in hyperocclusion. Well, then I would just adjust it and try to save the patient because this has happened on more than one occasion where, hey, I've been to like 3 endodontists, I'm hurting and nobody wants to do any work on me. And so, okay, well, again, I take my X-ray, I got to do my own due diligence, right? And then put them on the T scan. I'm like, well, this tooth is really in hyperocclusion. Why don't we adjust this down to where it kind of matches the rest of the bite and see if it doesn't calm down and go away. And I think I've done this like 10 times, and 9 times out of 10 didn't have to do a root canal.
Yeah, and I think you always want to do a T scan before you touch any tooth, period, because you want to know what's going on with that tooth.
Um,
But you just got to decide what makes sense treatment wise on those patients to start with. Um, One last question is, if you have someone that's looking to use T-scan more in practice, maybe they're just using it on full mouth cases or maybe implants of full mouth cases, but want to start using it more. How would you tell someone to get started with implementing T-scan further into their practice?
well, I would start using T scan on, like I said, all of your implants. Those have to be checked because patients are poor historians. We like to think at dentists in dentistry is if I'm way off, the patient's going to tell me that they're way off. First of all, that's false. I haven't published that paper yet, but patients are poor historians about telling you how close something is. Um, and um, when it comes to something like as technique sensitive as placing implants, they're expensive. And it doesn't sit well to tell a patient who just spent $7,500 to have an implant, custom abutment, crown, tooth extraction, bone socket preservation grafting, that now they have to get numb and you have to drill that out and put another graft in there. And oh, by the way, I know this is not good, but I'll do it for free. Dude, I would be so pissed that you had to do it at all, especially if it was preventable. Because one of the things that comes in, it's always interesting because patients that come in, and I've got patients that travel all over the state, all over the West Coast, the country, and out of the country. And one of the things that always comes up is, why is this not in more dental practices? And I'm like, I really I can't answer that. I know what I value. I grew up, not grew up, but before going into dental school, I was a researcher. And so we had all kinds of technology. And when you're sequencing DNA, you can't see it. You have to trust the machine is correct, right? And so I feel confident after using T-scan since 2009, right? What is it? It's 23. So I know the machine is right. And so the next question is well, if it's so good and you're able to have these these great results with it. How much does this machine cost? And I'm like, around $10,000, $11,000. They're a lot. And you know what the patients say? That's it. How come my dentist doesn't have one? The chair I'm sitting in costs $10,000. They got 5 of those. I'm like, yeah, I don't know. That's a good question for your dentist. Go ask them. Let them stumble around. I don't know. I can just tell you what I do, right? I don't try to put words in people's mouth. And as a dentist that doesn't have one, what's your answer going to be?
Real quick too, one of the questions is, what is the website to get discount with T-scan book?
Yeah. Am I still sharing my screen?
Yes.
Okay. Okay, you're going to look for IGI Global. Click on that link. And when you see the search bar, just type in Kirstein.
So it's not showing, it's just showing your presentation. It's not actually showing your.
Oh, okay, hold on.
So you probably have to share that part.
Can you see it now?
Yes.
Okay, so go to IGI Global, right? Come up to the search bar. I type in Kirstein's name, and here they are right here. Here's first edition. Here's second edition. And when you click on it, okay, so you can get the ebook and the hardcover for $1,000. If you put in the IGI 50, it's 50% off. On demand for individual chapters, less than $40. And I think you can still use the IGI 50 to get 50% off of that. All right. And then if you come down, and what I said was chapter 4, which is on T-scan recording dynamics, and then chapter 7, employing T-scan EMG. This is more the DTR chapter, but both of these, I would read 4 and then 7. 4 is going to be all T-scan. Okay. Anything else, guys?
I think that's it for all the questions. And like Dr. Sutter says, I think when you're talking with patients, the simpler that you can keep the information, because you're going to be correlating, signs and symptoms and other things that the patients come in with. The simpler you can make it, because patients are going to understand it. They're going to know what you're looking at. They're going to, definitely participate in what you're seeing with it as well too. So the simpler you can keep it, the easier that conversation is going to go with those patients. So I want to thank everyone for taking time out of their day or their evening, depending on where they are in the world, for being a part of this webinar. And of course, I want to thank Dr. Sutter for taking time out of his evening to be here as well. So this webinar has been recorded. So there'll be access to it probably at some point in the next day or two if you want to rewatch the webinar. Again, there is a survey that will happen towards the end of this. So if you can take time to do the survey, we would appreciate that as well too. So without further ado, thank you for your time.
Thanks, Shane. Appreciate it.